Heights is tucked away deep into the Ozarks for a little getaway with his family. Dr. Dana Hawkinson is down south in Florida, also getting some much needed rest and relaxation. They will be back next week. And we're going to check in with Dana here in just a moment down in Florida. He's joining us remotely. So they are there on vacation, but I'm here with you guys. So actually, it's not too bad for me. So I've got Dr. David Lisbon with us. He is one of our emergency medicine doctors here at the health system. So glad you're with me.
Thank you.
Good. And we've got Patrick Salih. He is the CEO of Vibrant Health. How are you?
I'm great. Thanks for having me.
Good. So you're going to talk a little bit about this big milestone that you all have hit.
Yes.
30 years here in the
We've been around for 30 years.
Great,
yes.
great.
We started as Turner House Children's Clinic and have grown and progressed over 30 years, but it's been a great run. Great.
Well, we will talk a little bit more about that. And Dr. Lisbon, you're kind of my wingman today.
Sure.
Maybe I'm more yours because I'm not medical, as I said. I ask questions, and you're our medical guy today. So,
Sure.
So thank you. So before we get to our conversation today, I want to get down to Dana Hawkinson, where our crew is a little jealous. How are you? How is Florida? The beaches look gorgeous.
I am good. You know, the beaches are nice. Again, there's not a lot of people here. Earlier, prior to the show starting, there was talk about everybody wanting to go to the beach. And I think it really does determine what time are you going to travel? Are you going to the beach? Are you going to the mountains? Because that certainly plays an impact. You know, I was certainly prepared to cancel the trip even 3 days prior to leaving. As we move further and further, and yes, overall the cases in the United States are going up. If this were 4 weeks from now, there was probably a good chance that I probably would have canceled and not gone. So that's very important, as well as understanding where you're going. As far as at the hospital, you know, we saw a little bit of a surge as the number of patients from 9 all the way up to 18. Right now, we have 15 in the hospital. 7 of those are in the ICU, and 3 of those are needing vents. We did not have any deaths overnight, so that's a very good thing.
All right, Dr. Hawkinson, thanks for sharing those numbers this morning. We've already got some questions for you, of course, regarding travel, so we'll get back with you in just a moment, so hang tight. Dr. Lisbon, I want to find out a little bit about what you are seeing in the emergency department. How have things changed? You know, from 10 weeks ago, we're telling people to stay away, and now we're asking people to come back into the fold. Tell us what you're seeing.
You know, we are seeing an increase in our volume. We've got a graph that actually depicts what's been happening week by week in our department. And it actually, we actually were a department that saw roughly 180, 190 patients a day. And at our lowest point, or our nadir, we were like 90 patients a day. So that was quite a drop. Actually, I'd never seen anything like it in my 25, 30 years of practice. And so it was very evident that the populace, again, took the advice of staying away. People were afraid of what might be they might be exposed to in the emergency department. But then we've actually had this gradual rise, and as we've implored people to not put off issues that they were experiencing and to come into the ER, we've seen that. We actually have experienced a higher admission rate, which is a marker for the acuity of illness, and that has been something that has been interesting to watch. We've had to, continue to tell patients, hey, if you're feeling bad at home, you've got hypertension, diabetes, congestive heart failure, lack of access to your medicines for some reason, get in here. We'll take care of you. We can keep you as safe as we possibly can from coronavirus. And so with those numbers increasing, definitely had lots of interesting interactions with patients. There's a lot of stress going on as well. So it's been heartening to see the volume increase and know that, people are availing themselves to our skills and our ability to assess them and place them in the right patient environments if they need to be admitted. And of course, reassure those who do not need to be admitted, do the proper testing, and even with our hospitals greatly expanded capacity over the last couple of months to do testing, to tell people, hey, you don't have COVID, we'll get back to you in 24 hours, or you do have COVID, you're safe enough to quarantine at home, or we see enough that says, wow, it's probably best that you come in the hospital. So that's been really great to interact with patients and really explain our rationale. I mean, my joy comes from demystifying medicine, so that's it's always good to do that.
Well, thank you for sharing that. And I do want to talk about, continue to talk about the numbers and this, the possibility of the second wave here in just a moment, because that will impact Vibrant Health. Patrick Salih, thank you so much for joining us.
Thanks
I want to find out, you've been around 30 years, not everyone else has. So can you tell us a little bit about what Vibrant Health does
Sure.
here in the community and how you're helping citizens.
Sure, absolutely. Thanks again for having us. So Vibrant Health was founded as Turner House Children's Clinic, started May 5th, 1990, as an all-volunteer pediatric clinic. We've served Wyandotte County for 30 years, as you said. Over the last 3 years, we've had a really strong relationship with the University of Kansas Health System that has helped us do a couple things. One, expand our services to offer care to adults as well as the pediatric practice we had, but also help us secure what's called federally qualified health center status. That designation is really important to us organizationally, but also from a community perspective. So we are a 501c3 nonprofit organization with 16-member board of directors that are all volunteer, and in fact, more than half of our board members are patients of the health center. We offer medical, dental, and behavioral health services on a sliding fee scale. So we do take insurance, we take Medicaid, Medicare, and commercial insurance, but for people that are uninsured, we have a sliding fee scale that ranges from $20 up to $80, depending on income. So, for us, as we think about the population that we take care of, certainly has been impacted in a major way by COVID, both from a disease perspective, but from all of the unemployment and the number of people that are in essential jobs.
What have some of those challenges been?
Well, so we've tried to make decisions where we're protecting staff and patients. And so, Dr. Lisbon mentioned the decline in volumes at the emergency room. We've seen the same in just trying to keep people out of clinic unless they have to come in. And we're a primary care outpatient practice, so take care of a lot of patients with chronic disease management and diabetes, hypertension, those kind of things. And so limiting the number of people that come in means we're delaying some of that regular checkup care. And so as we think through and have worked through how do we provide care, it's been really tricky for sure. We've started doing telemedicine as the health system has, and that's helped us reach more patients. But decreasing volumes has definitely delayed care for people.
And today I want to talk a little bit about healthcare inequality in our community, how that impacts everyone. We'll get to that topic in just a little bit. I think we want to open up the conversation to any media questions.
I have one from Katie Moore with the Kansas City Star. She wrote and wanted to know, Kansas is at a 2.2% death rate compared to Missouri at a 5.5%. What might some of the factors in this difference be?
It's not completely clear to me. I had been following those numbers, and they were much closer, perhaps, 3 to 4 weeks ago. It was like a 2 versus 3%. To hear that it's now 5% is certainly alarming. I am not 100% sure if once again, the concentrated clusters that St. Louis County has, as well as some of the other areas in St. Louis might be driving some of that. Mm-hmm. I do know that I think the populations are somewhat equal in terms of, I think, people over 65. I don't think there's a great difference there. I would say overall, I suspect Missouri probably has a little bit more urbanity, if you want to use that term, with it. But I'm not 100% sure why that rate is different, to be honest.
Dr. Hawkinson, do you have anything to add to that?
Yeah, I totally agree with Dr. Lisbon. The other issue is these numbers are going to change. They're going to vary from week to week, 2 weeks to 2 weeks, depending on what window you're looking at. I certainly think that you have Kansas City, Missouri, plus you have St. Louis, Missouri. So those are two fairly big urban centers compared to, say, Kansas City, Kansas, and the metro area here on the Kansas side. So I think that probably plays a role in it. We have, I think, been really fortunate, and we saw that the clusters out west in Kansas, really, we haven't seen a lot of those hospitalization or death rates, and I think that's a great thing. But I think these numbers are going to continue to change until we're able to look back retrospectively at everything. And we keep saying 2 weeks, 2 weeks, 2 weeks. These are types of things that we're going to have to continue to evolve and look at 2 weeks down the road, 4 weeks down the road, things like that.
So a new study just came out from a Harvard researcher saying that it was 100,000 deaths. Now they're looking at possibly 200,000 deaths by the end of the summer. Dr. Hawkinson, I want to get your thoughts on that here in just a moment. But Dr. Lisbon, is this a reality? Where do we stand today, and what are your thoughts on that study?
I'm not familiar with all the specifics, of the study. When I think Dr. Fauci estimated the 100 to 200,000 number, and we passed that 100,000 number, I've been somewhat heartened that, or rather feeling better about the fact that presently it's 114,000. So if what he predicted was to come to pass going straight forward, it seems to have slowed, I would say, the death rate. I do think that with the ability to look at how we treat COVID, gaining insights from folks who've had the worst cases and worst morbidity and mortality with COVID, I think the medical community has figured out a little bit about what to do about interacting, or rather impacting early the course of the disease, meaning, decide who needs to be intubated or decide who needs to just have high oxygen therapy, utilizing all the adjunctive measures to stabilize people's other medical conditions. And I suspect that to some extent the at least slowing in what I think is the death rate is probably due to just the learned experiential knowledge of folks on the front line like myself and Dr. Hawkinson as intensivist tried to deal with this pandemic.
What do you see that second wave looking like?
So it's
COVID
interesting.
looks like.
Yeah. I looked at the numbers that our health system has provided. Like right now, there are 10,650 cases in Kansas, but it looks like to some extent the rate of new cases is at least flattening. There's still these spikes which we saw after Memorial Day, but I did note that none of them are still as high as early in May. So I think on May 2nd we had 71 new cases in I believe Wyandotte County, and then a few days after Labor Day it was only 59. So we're seeing spikes, but they're not as high as the height of our interaction with COVID. Now, as far as what happens in the future, I am certainly a little concerned. I've looked around the country and looked at some of the spikes in places like Alabama, Florida, South Carolina, and it does make me concerned that, wow, and I'm just like everybody else, want to get back out there, want to have dinner with folks, but I think we've got to just, because it's not beat yet. We haven't beat back coronavirus yet in terms of its infectivity, in terms of its potential to spread in crowds. So I'm still I'm hugely in favor. You got to continue to wear those masks. For our immunocompromised, hypertension, diabetes, cancer folks, you just cannot do large gatherings.
And that's the message that we've
that's the
been
message I
hearing
would
from
have.
you all.
Yeah.
We're going to get to community questions here in just a minute. But Dr. Hawkinson, anything to add? I mean, how do we stay away from being a part of that large number here in our area?
Yeah, that's tough to really know. Again, I think we may have passed, was that 2 million cases in the United States or so? Say we have minimum of 300 million people in the United States. That's still 1% or less than 1% of the total population. Look what has happened already. Look at the devastation that these surges has brought, especially in these urban areas where you have lack of adequate drugs when people are on ventilators, lack of rooms, lack of ventilators themselves. So I think we still have a long way to go. There is really relatively few amount of infections that we know of. Now, of course, you can talk about testing and things like that, and certainly we're probably missing cases because we're not testing. But certainly look at what has happened so far with this relatively little amount compared to our total population. And if you project that forward, it certainly could be bad. But to Dr. Lisbon's point, continue to do those things that we've been talking about, especially avoiding large congregations and groups, whether that's churches, football stadiums, concerts, things of that nature. If you can avoid being in those confined spaces, if you can wear your mask, if you can do that hand hygiene, because society is going to continue to open up. And so it's really going to be incumbent upon every individual to be responsible in that way, to really protect themselves, their loved ones, and others.
Patrick, how do you all plan for that second wave? What are your concerns when you hear about these high hitting numbers?
The first concern I have related to the numbers going up is that what we're seeing in our community testing, we're doing in partnership with the Unified Government Health Department and their Health Equity Task Force, we're doing community pop-up tests 3 days a week now around the community free COVID-19 testing. And we're seeing a decline in the number of people coming to get tested, where 3 weeks, a month ago, we were testing 90 to 100 per day. We're testing 35 to 40 per day now. And so, when you start seeing numbers go up, my immediate concern is that we're not testing enough people to stay on top of this, and we need more people who maybe are lightly symptomatic to be tested.
And why do you think they're staying away?
I think there's a number of reasons. I think there's fear of the system. I think there's still a lot of unknown around frankly, the fact that you can survive this, that lots of people survive this. I think there is a significant amount of fear of to what happens after a positive test, and people are scared of that. And frankly, there's a lot of people in Wyandotte County that are uninsured and think about it also from a financial perspective. So
Are you seeing that here when you see people come into the emergency department?
Absolutely. You know, emergency physicians are great with stories, and I had a gentleman who came and was triaged to our area that we try to treat people who are likely positive for COVID, but are not so ill that they will need the intensive management of our main emergency department. And the gentleman was actually traveling. He stated he wasn't insured. I actually talked to him and said, boy, your x-ray looks like you have a decent chance of this being the COVID virus. His oxygen saturation was a little bit low, but really he was otherwise healthy. And his labs came back, they were a little bit off. And I said, you know, my personal medical recommendation is that you be hospitalized. And he really said, doctor, I know what those bills can be. I don't want to. And as much as I tried to counsel him to let him know that, you know, health systems have ways of course, trying to, or rather working with you and setting up payment plans, et cetera, he still elected to go home. And because, you know, I was just worried about him, I was like, wow, you know, he may be positive. He'll go out and intermingle with other people. He's going to go back to, you know, where he said he was from. And what was interesting was he actually did feel worse and came back. And because of our ramped up testing, 4 or 5 hours later, by the time he came back, we had the test back and it was indeed positive. So
But he'd already gone back out there.
Yeah, but he'd been back out there for a little while. But at least he came in and came back. And so once again, one of the things I stress, I teach residents is like, you know, communication is everything. Even if a patient doesn't agree with our medical assessment, our job is to let them know that we're here, you know, for them should they change their minds, and them having a different opinion of us is not an indictment on their decision-making capacity in many instances.
Gosh, that's just a part of COVID I didn't even think about, and maybe a lot of people out in the public haven't thought about. Kind of this what you don't know won't hurt you, which clearly isn't the case,
Right.
but having that open dialogue and making people feel comfortable to talk about that. We're going to continue this conversation. Jill, do you have any questions from the public?
As always, yes.
Yes.
They have a lot of questions, and they are very broad. I'm going to start with one, and I'm going to summarize. It's from Jean. They're talking about that this disease can be a plane ride away, and they're wanting to know what is the impact on one county to another county here in the metro. We look at pockets, example for Wyandotte being hit really, really hard. How does that impact me if I live down in Johnson County or I live in Blue Springs? How interconnected are we, and what can we do to help?
I'd like to hear from both of you on that.
I think the answer to that is we're all incredibly interconnected, and you can't assume that if it's happening in Wyandotte County, it's not happening in Johnson, or it's not easily accessible. And the story Dr. Lisbon just shared on the gentleman coming to the ER and then leaving is a perfect example. And these borders are very loose, and so people are traveling back and forth. People are going to restaurants. People are doing all sorts of things where we're going to interact with each other. And I think that this pandemic has shined an additional light on what many in healthcare already knew, in the disparities, both racial and economic, in our health system in a broad sense, and that investment in care for people who are uninsured and at or near the poverty line, and for all sorts of reasons, matters, and it impacts everyone.
Yeah, Dr. Lisbon,
Yeah.
how do we help people understand, how healthcare inequity affects, even if it affects you indirectly, how do we make sure people understand that?
Well, I think Patrick's point is 100% accurate, which is not only is it kind of porous, I mean, people in one community may go to work in a community that has a lot more job opportunities. And so you can't separate yourself with who you're going to interact with, because in some instances, folks go where there's opportunity. And if some communities have more opportunity than others, it becomes natural that their workforce might come from various places. And I think the Johnson County, Wyandotte County comparison is incredible. It's I looked up the numbers. The median income in Johnson County is something like $75,170, and the median income in Wyandotte something like $43K. So that's a $30,000 difference, even after taxes. That probably comes down to somewhere around $800 a month that could be utilized for people to change some aspects of their life, not least of which, as Patrick said, might be insurance coverage.
Sure.
You can actually do that. And so, they did a study in Chicago, a couple of neighborhoods just like ours, side by side, different ethnic variation in terms of population. And same thing, 101,000 median income in one community and 60 in another. So that's a $40,000 difference. So these side-by-side
Right.
communities that are separated by ethnic concentrations, racial concentrations, if you want to call it that, do mirror the ability to have resources and access. And that's not coincidental.
There's another point, data point on Dr. Lisbon's point about the median household income, and Wyandotte County and the Wyandotte County Economic Development Council has done a ton of work to improve some of these numbers, particularly the household income number and the jobs numbers. But if you look at income or job payment, salary, weekly wages kinds of numbers across the state, Wyandotte County is near the top, right behind Johnson County. So there is a gap. Now, like I said, the community leadership and Economic Development Council have done a lot to raise that median household income, but there's still given that data you cited, there's surprisingly high ranking where Wyandotte, and some of that's the health systems in Wyandotte County. There's some big employers, but the wages, weekly wages in Wyandotte are pretty high.
And what does that mean then, healthcare wise? I mean, what does that mean for the rest of us to better understand that?
So to me, Dr. Lisbon nailed it. It is the crossover of opportunity and where people work versus where people live.
So we're all in it together. We can't escape
Correct,
it. So
correct.
it's
It speaks
all
to the question Gene had around how we're connected to each other, and it's not going to stay in Wyandotte County.
These are really interesting. Did you have something else to add, Dr. Lisbon?
No, I think on Pat's point, I think the issue of access is kind of a very interesting one. I sit here with Steve Stites usually, and Steve, I'll just say it, he's a few years my senior. But even though we're categorized different racially, we have access that allows that at age 50, we both got colonoscopies, right? Mm-hmm. And that had to do with the fact that we had healthcare providers, we had insurance, and when our physician said, "Hey, you're 50, time to get a colonoscopy," we did that without impediment. We did that without having to worry about an employer who wouldn't let us off. We did that without a travel issue. We did that without having to worry about who's going to watch children. So some of it is, once again, the ability to be tied into a system that provides that basic framework for continuing to maintain your health, which is what FQHCs, which I would give a shout out to, do so well. I mean, organizations like Vibrant Swope are really essential to what our community needs in terms of health maintenance.
Thank you for laying that out. That makes a lot of sense. Jill, do you have another question?
Yes, Chris says, this is a really sad question. We are having my mother's funeral service tomorrow near Tulsa. We are requiring masks. Everyone is going to want to hug my 81-year-old dad. Do we allow it? If we're wearing masks and we have lots of hand sanitizers, it is such a difficult time. He needs hugs.
Yeah. That is a difficult time. Death, funerals, and even illness during this time is extremely difficult. I think it's important to note, we have said before that, hugs themselves are really short amount of time, but when you have 80 people or more people, it could be somewhat dangerous. If everybody's having a mask, if in general you are really going to try to not be in confined spaces, I don't know if you'll be inside or outside for the funeral or the service, that will help as well. Continuing to hand sanitize. I think, making that judgment once it's there is going to be probably the best thing you can do. I don't want to say no hugs because, again, we need, and we've talked about this before, emotional support, mental support. This all helps. If you can keep people as far away from people as possible, and then maybe a second or two of a hug, it may be reasonable. I think you just kind of have to understand all of those factors and make that decision, at that point in time.
Gosh, these are those stories we hear that really help hit home
True.
where we've been and really where we still are, right?
Yeah. It brings up this concept that my organization that I belong to, the American College of Emergency Physicians, has coined this term called COVID lateral damage. And it speaks to, last week I showed a slide with the waves of the pandemic, and it speaks to all of the different adjustments we're having to make, like, for instance, this third wave that impacts interrupted or chronic care that's needed, and how to usher someone into, the death process. And doing sometimes that alone has been very striking to healthcare workers. We sometimes become part of that grieving process when it happens acutely. I see it in the emergency department. But with the present situation of not having any visitors, I think people are having a lot of crisis around a loved one having to pass away alone, or to be alone for an extended amount of time, not to be able to have that particular human touch while they're on a ventilator. It's very wounding, I think, to people.
Devastating.
Yeah, it's happening, and healthcare providers are experiencing it, and it's a tough part. So yeah, this thing called COVID lateral damage, because there are just so many waves that this kind of pandemic and the ferocity with which it came on is exposing us to, and having us actually improvise on the fly in terms of how to best manage it for patients and ourselves.
Another similar question, same kind of thought. Jean asks, what are your thoughts about attending a couples dance indoors, 50 people, attempting social distancing? Should we wear masks?
I would avoid that situation. I think it goes back to, again, confined spaces, couples dance, 50 people, the amount of time you're with there. If you're dancing, it's probably going to hard to have a mask on without being, feeling claustrophobic or not able to get enough oxygen. I think right now that is probably something that I would avoid. I wouldn't necessarily say that's any different than the choir practice that we've seen it has been published on as far as spreading disease. I think that's a little bit more of a risky endeavor to do the way that was described.
Hey, Dana, I have a travel question for you. So Mike had asked yesterday, and I wanted to make sure we got his question in. He has he's part of a scout group, and there's going to be several hundred kids and adults present at a camp, a communal tent, 2 per tent. Yep. There'll be cots combined with communal water filling stations. There's going to be some classes, campfires. How safe can that be? And what extra precautions can they take over an 8-day camping period?
Yeah, I think that still sounds risky. Number one, you have so many people together. Although you are outside, we're probably certain circumstances going to be in a situation not unlike the protesters or the demonstrators, where you're going to be together for a little bit for programs or things of that nature. I think the most dangerous thing, however, is the communal part about that, whether it's water source or other communal thing. We know the father of epidemiology, John Snow, when he identified the cholera outbreak in London, it was because of a communal water source. So I think communal things are going to be very dangerous and going to be very high risk for spreading this infection. And again, the more people you have, the more time you are actually in a communal setting at a program or watching certain things. I know those occur in Boy Scouts and Girl Scouts camp get-togethers and things of that nature. I think, there are probably ways you can reduce the risk as much as possible. Maybe taking out some of those communal things is going to be one of the ways, but I think certainly the way it's been described now, seems fairly high risk to me.
Risk with everything. Jill, another question from the community.
Tamara asked, there was an Israeli study released that showed 40% of COVID recovered patients had ventricular damage. Have we found this in America to be true?
I don't know if we've had a study that mirrors that one. I think that cardiac damage and or compromise with COVID has been seen, sometimes in the form of a condition we call myocarditis, sometimes in the manifestation of the heart's decreased pumping ability, which we call the ejection fraction. But I'm not aware that we've duplicated that number to that extent. I really am not. Are you, Dana?
No. I would agree with you, Dave. We, as you have talked about, we know that in critically ill patients, we have seen that their heart function has been compromised. We don't know if that's due to the virus or if that's due to the critical illness, which in itself can cause cardiac compromise. We suspect that there is probably some effect of the viral illness on the heart just because the receptors that the virus attaches onto and gets into cells is found in the heart. However, interestingly, there was the Lancet study that looked at autopsies, I believe, of patients in Louisiana. There was another New England Journal article that looked at autopsies as well. And when they stained the heart muscle and some other organs for the virus itself, they were unable to find the virus in those organs. They did find it in the lungs, of course. So I think there's a combination. At some point, there may be some direct viral effect on those tissues because we know the receptors are there. Those autopsy reports, they weren't able to find it, at death. But certainly we know that the inflammatory process is also going to be playing a part in any of the end organ damage that we're going to be seeing.
Dana, I have a question for you, and this is important as we start to invite more and more people into our home, even at a distance. Tiffany asked, are portable home filtration devices such as HEPA, UV light, or electrostatic filtration devices effective in removing SARS-CoV-2 from the virus from a room?
We know certain things such as chemicals, UV light will all have an effect because SARS-CoV-2 does appear to be, fairly weak and certainly susceptible to any household cleaning product. I don't think there's been any studies specifically looking at that type of situation in the home. I don't think it would be harmful as long as you make sure you have a device that's not otherwise harmful to you. I don't know how much that will help. The main things are going to be, again, cleaning high-touch surfaces, washing your hands frequently, doing the things that we've talked about. Again, I don't think that those necessarily will have any deleterious effect. It could be beneficial, but I wouldn't count on that to remove SARS from your home.
Another question from the community, Jill?
Allie and Linda, two separate people, same question. They're asking about research around type A and type O blood types, showing that type A might be people that are more susceptible. Excuse me. And are we as a hospital taking greater precaution with them because they have a by blood type?
I am not aware of the veracity of that outlook, so to speak. I'm just not. I don't know it to be valid or true as of yet.
Dr. Hawkinson?
I would agree 100% with Dr. Lisbon. We understand that things like sickle cell trait and malaria can have an effect and reduce your susceptibility to that. But again, malaria is a parasite. This is a virus. There has been other things proposed a few weeks ago that maybe blood type makes you more susceptible or less susceptible. I am not aware of any research which definitively says one way or the other. I would continue to say that it doesn't really matter what type of blood type you have. You need to continue to take the same precautions.
We have time for a couple more questions, Jill.
Nancy says, I'm super claustrophobic and find wearing a mask difficult. She said she's even passed out once. Is it better for her to wrestle with that and constantly be moving the mask, or what do you suggest?
Dr. Lisbon?
I think I still think a mask is very important until we get a little bit more on the other side of this. I find the hospital mask that we use to be lighter because I'll tell you, I have a cloth mask that was made for me. I'm a Marvel comic fan.
Oh my gosh, that is so cool. I'm a Spider-Man. I love it.
But it's a little hotter and a bit more constricting. But I think the hospital ones, that not the N95, but the regular hospital masks, yes, are much better. That Pat has in his hand, and they seem to be a little lighter. If you're claustrophobic even to that extent, I would still go with having it and maybe putting it up when you're about to enter areas where there seems to be more concentration, a greater concentration of individuals might be a strategy. But I think it's something that works, and I think we've got to continue to do it.
So it's a non-negotiable, really, if you're going to be out in public in big spaces with lots of people. Jill, last question.
Antibody testing. Do we have it? When are we going to have it? And are you using it in Wyandotte County and at Vibrant?
I'll defer to the doctor on some of the specific questions around antibody testing, but we are not using it currently. We are exploring timing on using it, and sort of efficacy of what are we trying to accomplish with using it. Right now, it seems to be certainly data would be helpful for knowledge and our understanding of this virus and what's going on. But as a diagnostic tool or creating a treatment plan, it so far hasn't proven to us that it's the right thing for us to be doing.
Anything to add, Dr. Lisbon?
No, I don't. I would probably defer to Dana about the antibody testing as of yet. What I know is it's not distinctly proven ready for prime time yet in a large sense, but yeah.
Yeah. I agree with both of you, absolutely. We are working on the health system, getting a platform. There were validation of 3 different tests to see which one was the best to use for the health system. Again, I don't think that we really understand how to use the antibody test on an individual level. It would be good, say, on a population level, to look at the prevalence of the disease and has it passed through this community or in what way. But certainly for an individual level, unless you are going to be donating plasma for help with the convalescent sera for patients' treatment, we don't really know how to use it. There was possible use, say, in college athletics, just so that we could evaluate if you've had infection by the virus. And then would that prompt something else like a cardiac evaluation or something like that? But that is a very specific circumstance. Otherwise, on an individual level, we surely we don't really know how we would use that at this point in time.
I think we have time for one more question from the public.
Yeah, and this is totally up to Dr. Hawkinson if he wants to reveal as he sums up his final thoughts for today. Everybody wants to know, where are you? Where is that beach?
That's a good question.
This beach is just outside of Tampa. So nothing too exotic, no out of the country, obviously. Wasn't lying. I am in Florida, just outside of Tampa on the Gulf Coast. So that's where we're at. Otherwise, final thoughts. I'd like to go back to one of the first questions about treatment and concern about finances. That is absolutely a concern every day. The health system gives out charity care every day. Our goal in the health system is to provide you with the best care that you continue to live. Not only that, but you continue to have the best quality of life as possible. Our healthcare workers, our physicians, our nurses, our therapists show up every day to continue to provide care for you and your loved ones, that we can ultimately get you out of the hospital and have your quality of life as best as possible. Specifically for COVID, I know that if I got diagnosed, I would want the treatment as soon as possible, because we know that in infection and things like cancer, the earlier you are diagnosed and treated, the better off your outcomes are. If I was diagnosed today and I met the criteria for remdesivir, I would absolutely want it. I would want the convalescent sera, and I would want some of these other monoclonal antibodies if I met the criteria. So we would just like to let people know that the sooner you get diagnosed, the better. And if you're meeting criteria for the therapy, we're going to give you the therapy. Again, the health system has given out charity care every year to people, because our mission is to continue to make you be healthy and continue to be healthy, so that you're around in the future.
Dr. Hawkinson, thanks so much for your final thoughts. We're going to let you get on with your vacation, okay? Thanks so much.
All right. Thank you.
Enjoy the beach. Dr. Lisbon, I'll let you kind of take it from here. What do you want the community to know?
Well, I think, during this time where certainly everybody's tired of sheltering in place, dealing with quarantine, dealing with masks, I think you have to do what we do in the emergency department every day, is kind of perform kind of a risk-benefit analysis when you think about what you're about to undertake in terms of exposure, or being a part of a crowd, or being somewhere that might put you at risk. And you have to do that with the sensitivity that is needed if something could be a final event, in terms of giving someone a hug, and whether something is something that really can be said that, boy, there'll be a time to do this, and maybe I should wait. So I mean, I've even had to do it myself. I've been part of the protest. I think the the things that brought upon that protest with George Floyd's murder were very psychically disturbing to me and a large swath of Americans. And I had to decide, wow, I'm a physician. It's going to be a crowd of some extent. I'm going to put on my mask, but I felt like to not go, the risk benefit of not, or being silent, of not engaging was worse than letting my voice be heard as well. So I think everybody has to do that, and I think we have to do that with a lot of thoughtfulness in this particular time period, and again, keep the faith that, what mankind and science has always been able to do is kind of get us to a point where we can meet a virus on its own grounds and ultimately conquer it.
Thank you for your candor on that
Sure.
this morning. We appreciate that. And Patrick, thank you so much for being our guest
Thanks for
today. It was so
having
nice
Yes.
to meet you. What would you like our community to know about the work you are all doing, and how can we help out?
Well, I think both Dr. Hawkinson and Dr. Lisbon have shared the importance of taking all of this very seriously, from wearing the masks and being thoughtful about that to accessing care. The health system has been incredibly supportive of our testing efforts, so providing staff to help with the pop-up testing and providing the lab work to run the test. And so I would echo Dr. Hawkinson's sentiments about the investment in care and treatment and so on from the health system. For me, that I would just piggyback on the seriousness of it and saying that I think as a society often we decide to delay things that are mild, and it hurts a little bit, but I'll wait, and I'm as guilty as anybody of that sort of thing. This is not the thing to do that with. And if there's any degree of symptoms, people should try their best to get tested. I know there's pop-up testing sites that the FQHC, Sam Rogers, and Kansas City Care Clinic and SWOPE are doing on the Missouri side. The Unified Government's doing some in Wyandotte County, Johnson County Health Department's doing some. We're doing some. There's opportunity to be tested, and so I think people that have any degree of symptoms should do that.
Well, thanks to all three of you for
Thank you.
talking about this really important topic. And we'll continue this. We're going to hear from Dr. Steve Stites in just a second. I'm going to give you a couple quick notes. We mentioned yesterday how we appreciate everyone sending in their questions and kind of staying in touch with us via social media. So now we want to see your faces. We're hoping that you will send in your pictures showing us how you're staying safe, how you're getting out into the community, whether it be going to restaurants or traveling in airports, just how you're getting your kids together and how you're doing it safely. So send those in, and we'd like to share those here on our update. On Monday, we have a really important show. Dr. Stites will be back to navigate this conversation. We've been talking about, you mentioned the protests, Dr. Lisbon, and the first responders and the frontline workers. Our guests and experts are with an organization called the Battle Within Frontline Therapy Network. They are coming together, therapists and doctors, and helping these essential workers as they are struggling through this pandemic and, of course, all the unrest that we are seeing across the country. So, again, Dr. Stites will be back to talk about that. So as we close this morning, again, thank you for welcoming me in for the last couple of days. Dr. Stites will be back on Monday. Want all of you to have a great weekend. And, of course, we will let Dr. Stites have the final word today. Have a great day.
Good morning. This is Steve Stites, Chief Medical Officer at the University of Kansas Health System. I'm deep down here in the Ozark Woods in southern Missouri, darn close to the Arkansas border. We made it down late last night after a great drive down in our car. My family's with me. It's like a nice bubble traveling down the highway. We used great infection control, had lots of hand sanitizer, made sure we were safe, wearing our masks, had to stop twice to get gas, got in, got out, back on the road. It is beautiful down here, and it's a great place to get away in the woods. You can travel, and you can stay safe, but you have to do it right. Remember the basic pillars of infection control have to go with you wherever you go, even down here deep in the woods. I'll see you next week. You have a great day.